everybody. Welcome to ABA Inside Track, the podcast that's like reading in your car, but safer. I'm your host, Robert Perry Cruz, and with me as always are my fabulous co-hosts.
Hello, Rob. It's Diana.
And it's me, Jacqueline McDonald.
I'm going to be honest, even though we're recording somewhat over the internet, I am still picking up like a minty, fresh breath from everybody in our virtual recording studio.
Thank you very much.
It's wonderful.
It's your new smell-o-my-phone.
It's exactly. It's the internet's gotten really good in these times we're all stuck at home. What do you account for that just minty freshness? What could it be?
I think it might be my new toothpaste.
Your new toothpaste?
Mm. I think it just might be my natural breath.
You are always minty fresh, Jack.
I know. I'm always very natural.
But you brush your teeth too, Jackie, I'm guessing, right? Like, it can't just be all natural.
That's personal information.
Oh, sorry.
I do brush my teeth. I love brushing my teeth.
Well, I'm glad you love brushing your teeth because on our podcast, which is about behavior analysis and behavior analytic research, we're going to be talking about what happens when individuals don't like brushing their teeth, or more specifically, what happens when individuals don't like going to the dentist. And not just like every day, the dentist, I don't want to go, but so much that they will refuse to go, may engage in challenging behavior to avoid going to the dentist. We're going to be talking about dental visit tolerance today. And because we are very, very fortunate for this, it's a November recording, right? We're doing this we're a little ahead, so I'm losing track of time. But we're very thankful that we've been able to get another awesome guest to join us on the show. One of the authors of one of our articles on dental visit care, Dr. Kelly McConnell. Kelly, how are you doing?
Hi there. I'm great. I'm so excited to be here, and I'm so excited to talk about something that is very near and dear to my heart, both personally and professionally.
Because you love going to the dentist, so.
I actually love going to the dentist. And Jackie probably remembers working next to me for so many years that I keep dental tools of various types on my person and in my workspaces at all times.
Even extra. So one time I was like, oh no, I'm going to the dentist. And she's like, don't worry, I have 5 toothbrushes in my drawer.
Yeah, no, it's no joke. And when you're ready, I'll tell you why personally I think I am that way.
Oh, okay. Well, I cannot wait to hear this, Kelly. It's a little, the background information that they just don't let you put in the pages you have for a Java article. You can't put it all in. Before we get into the secret backstory of research, why don't I share with everyone what articles we will be discussing tonight? So the first one, and this is kind of a background article, full disclosure, I sort of just typed in dental desensitization, dental well-being, dental care, kind of a lot of the terms that you might see around dental research, and then dentist, because I wanted to see what do dentists think about all of the work that's being done, working with individuals to help them get to the dentist. So this one's by Apukutun from Clinical, Cosmetic, and Investigational Dentistry, not a journal I think we've ever talked about before, who wrote an article, Strategies to Manage Patients with Dental Anxiety and Dental Phobia, Literature Review. That is from 2016. So that's kind of a deep background. What do the people who aren't behavior analysts say about going to the dentist?
Rob, do you think 9 out of 10 dentists would agree with that article?
I suppose so. There were a surprising number of dental journals. I was shocked. I thought they'd solved all the dental problems and they had no more research to do, but I guess not.
In its entire field of medicine.
I know, but I thought dentistry was one of the fields where it's like, we've done it. We've done all the research. There's nothing more to learn. Like, we know it all about the teeth.
No,
Maybe not.
Maybe not.
No, I don't think so. And then there's all kinds of dental patients. And so that makes it even more, varied.
That's true. That's very short. That's very close-minded of me to think we've only got one dental journal to pick from. But for our purposes for the show, I didn't think everyone wanted to listen to us read about a bunch of dental journals. It's not really the focus.
What else you got in the pie?
I got some other ones too. Got dental desensitization for students with autism spectrum disorder through graduated exposure, reinforcement, and reinforcement fading by Carter, Harper, and Lucelli from the Journal of Developmental and Physical Disabilities, 2019. Effectiveness of using non-contingent escape for general behavior management in a pediatric dental clinic by Allen and Wallace from Journal of Applied Behavior Analysis, 2013. And Dr. McConnell's article, Functional Analysis and Generalized Treatment of Disruptive Behavior During Dental Exams by Dr. McConnell, Sassy, Carr, Solinsky, Courtemanche, J. Jallo, and Cheney from the Journal of Applied Behavior Analysis. I think it's online first at the moment. So it's got that great 2020 99999, online nomenclature at the top, which is always a pain to cite. but I'm glad I can get it so quickly.
Coming in hot
hot off the presses. All right, Kelly. So you teased the listeners with a history of your own sort of dental view. So please tell us more about this.
So personally, when I was very little, while I still had baby teeth only, and before I had permanent or adult teeth, the proverbial they knew that I was going to have a serious overcrowding issue. As they put it, I had a small mouth and big teeth, which is real flattering and has obviously stuck with me to today. So what began from there was what feels like, but mathematically can't be true, but feels like a 20-year-ish saga, starting with pulling several of my baby teeth in order to sort of usher in my adult teeth quicker.
Oof.
And then braces, headgear, retainers, tightening. Oof. I mean, I was the little girl Darla in Finding Nemo who taps the glass. So I had more than my share of experiences with, dental contexts, which are, on a good day, usually unpleasant. So certainly a strong history myself experiencing this, which, then fast forward to my early clinical years and where I was sort of as a teacher and even a clinical specialist, sort of often charged with going on dental visits with our residential students. Then I got to experience it professionally.
I'll be honest, that's one of the best segues into both the topic and who you are for the listeners I think we've ever had. It just really flowed. You got the whole story down. That was excellent.
Great. Thank you.
Kind of on that subject, any other kind of background professional information you'd like to share with the listeners?
Now I'm the assistant director of client relations for the ACE ABA software system at the New England Center for Children, but I'm an adjunct professor at a couple universities, but I did get my start in our residential program. And again, as I mentioned, sort of as both a teacher and a, clinical specialist. First of all, the New England Center is very lucky to partner with Franciscan's Children's in Brighton, which serves a wide range of populations across a wide range of medical and dental therapies and treatments, including a pediatric dental clinic, where the majority of our residential students are seen for prophylactic or preventative care, all the way to more advanced invasive procedures. Mm-hmm. And again, as someone who as a teacher attended these appointments, and then someone who was often, a part of organizing and facilitating these trips to the dentist, first of all, resource intensive. I mean, we would often have to send, multiple staff and sort of rearrange an entire schedule just to get, one student there safely, completely anecdotally. Sometimes when medications that were supposed to sort of help in some way with the visit were given, we literally wouldn't notice anything until we were safely riding back to school in the van, which is not when we needed it to kick in, right? Yeah. And then during these appointments, it was obvious that in many cases, the students were distressed. The dentists were sort of like not able to get done what they wanted to get done, or not with the, sort of quality that they were hoping to get done. There was often restraints that needed to be used, just to maintain safety. And if you want to make something that seems unpleasant even more unpleasant, then, add a restraint. The teachers are just trying to manage as best they can. And so it always felt sort of like, they're experts in what they do in providing dental care, especially in that clinic. We're experts in behavior management. There's got to be something better than this, right? And I was really struck by that in all my years of attending. And sort of by the time I was looking for a dissertation topic, this felt really, really ripe for intervention.
I mean, that just sounds so very, true to, I think, what we see in the articles. For any of us who, I think I only had to do maybe 1 or 2 dental visits when I was still, working with individuals at a residence. And it did seem like one of those things of, this could go very wrong at any moment. And I worked with adults at the time, so they had a longer history with the dentist, and I think it had been successful. So we never needed to use restraints, but there was always that sense of, how did we get here? Are we just fortunate? These are clients who just like going to the dentist. And that can't be, because, I mean, I think about going to the dentist. At best, it's a giant inconvenience. At worst, it's like, I don't want to go. So many of the basic procedures are associated with either pain or potential for pain. They sound terrible. Like even when everything's going well, it just sounds awful to be having them doing that scaler in your mouth. You know, if you have to do a meaningful procedure, you know, like a root canal or anything requiring sedation, I mean, that goes beyond, I think, even the research here. I think we only got to like the basics of, you know, going to a cleaning, right?
Well, some folks have to be sedated just to do a cleaning.
Yeah.
Because of the, you know, behavior that you see. But every time I go to the dentist, this is what I think about, Kelly, is, you know, I find this very unpleasant, uncomfortable, and at times scary. And I, you know, understand what's going on. And I haven't had a history of being really fearful at the dentist or having anything happen that was surprising or shocking or painful or scary at the dentist. So just imagine what we're asking of our students or our clients to go to the dentist, even to do just a routine cleaning. It has to be a very overwhelming, frightening situation for some of them. And at the same time, it's something that has to happen because we have to get our teeth cleaned. So how can we make this a better experience?
Right, exactly. And the avoidance just makes things all that much worse. And the long histories of problems at the dental visits, you know, you can see that it like gathers momentum. And then, you know, in some cases you're dealing with now individuals who've been able to sort of hulk their way out of, you know, the procedures in one way or another, or are banned from, you know, the last resort people that should be able to help. So yeah, no, it's and again, same thing, you know, I kind of like it, you know, as I mentioned, oddly, I enjoy going kind of in a weird, like, now I just want to hear about my teeth and all these kind of weird things that we can unpack at some other time.
I thought you were being facetious when you said you loved it.
Yeah, Kelly, sounds like some sort of a Stockholm syndrome situation.
I know. Well, oddly, despite my history, like I said, now I carry toothbrushes like a second job of mine. And I kind of want to go and be like, you know, how does everything look? And I want to like look at all the x-rays and stuff like that. So it's something that we should examine. But at another time, but I had to have a filling filled or whatever just a couple weeks ago. And I'm literally like, had just talked to the dentist about some of my research. And then it had the Novocaine or what, it hadn't settled in time. And I could feel when a drill kind of touched my tooth.
Gross.
And I was like, I was wringing my pants, you know, I was like really, really engaging in because I was like, wow, if you lose it now, you just told him about the research you do, that's going to be like super embarrassing, right? So you got to hold it together. And so just like you said, Diana, like, even being super aware and kind of being borderline one of those people that kind of enjoys going in general, it even then can be so unpleasant. So
right. And you think about the rewards that are offered, right? It's like a sticker.
Right.
Right. Or like a small prize. That's not going to get you through.
No. Yeah. No, definitely.
I guess we can all kind of agree with, and I took this quote directly from the Allen and Wallace paper. Going to the dentist can be a pain. That is, I was kind of shocked that one made it through the editor.
No, I like it. It's so cheeky. I love it.
I bet the editor put it in there. They're like, guys, you're really missing an opportunity here.
There's a comedic editor that you.
Yeah. Or somebody was like, man, yeah, this is it. This is my contribution right here. Love it.
So in reading the articles, I think, from my perspective, I'd read the Allen and Wallace article before. So it was nice to see updates to some of that research, because I think when I'd read it way back when, it had been like, oh, it seems like contingent escape. That's the answer. Okay, done. But there's been so much more research, certainly Kelly, your research since then to sort of look at more deeply into function of the dental, whether we want to call it fear, dental avoidance, and different procedures that can be used. But I was really curious, where do dentists stand on what can they do? Because in reading the articles from the behavior analytic field, it did sort of seem like dentists wanted to help. They understood that there's a huge percentage. I think, one estimate or from a survey was like 20% of children don't like going to the dentist and become disruptive around the dentist. And that's just children, all children, not just children with ASD. So what did dentists, do about this? Because certainly the dentists all seemed very supportive, but there was also a sense of, I don't have time to do a behavior management program. I have to do dental work in a couple of the articles, at least, especially if it were dentists who weren't specifically working in an environment where that was their primary job or their primary clientele, were individuals with disabilities. So it does appear, and certainly Kelly, if you've seen other things or in your contact with Franciscans, please add in. But it did seem like a lot of those basic recommendations were things about the toys as positive reinforcement, and that behavior management is something you should use, though exactly what behavior management wasn't super well defined, at least from the dental journal perspective. You want to make sure your waiting room, they do talk about the waiting room should be enriching. You should have nice lights in the waiting room. You should have magazines to look at. There's an acknowledgement that, like you were saying, Kelly, that once people start getting scared of going to the dentist, the easiest way for them to not be scared of the dentist is to just avoid going to the dentist, which works in the short term. But then when you get a cavity or your teeth are rotting out of, your skull, you're going to have to go to the dentist, and it's not going to be a cleaning. It's going to be, a root canal or tooth removal or implants.
Short term versus long term.
Short term versus long term. Yeah.
Maybe.
I'm sure we all have a friend who's like, I haven't been to the dentist in 10 years. And then you see them and they went to the dentist and you're like, oh boy, I went to the dentist.
Yeah.
Towards your point about resistance to, or not even resistance, but, what they can do in their time, I do know, and this is direct experience, that in some cases, depending on funding, there is actually rules about what can be charged for time. And it's very specific to performing work, in that it can't be time that is devoted to behavioral support, if you will. And so what that means is that an appointment, but the flip side is that means that an appointment that takes longer because they're engaging in problem behavior is also going to be problematic for the same reason. But that overtly engaging in behavioral management that is anything short of do what we need to do to get it done is a risk of losing funding based on insurance structure. And that's I'm painting very broad strokes because I don't know much more than that, except that was a legitimate concern at Franciscans, where we were talking where schedules are tight and everything is really tied closely to describing what was done during a visit.
Wow. And I don't think that was as reflected in any of the research. That is an interesting fact that it's, well, I guess it's not surprising. Like so many things, doing the best job isn't exactly what insurance is looking for. They're looking for, it has to meet some sort of criterion based on the billing cycle, right, or the way billing works.
Right. And so that makes sense then if a lot of the recommendations are these things that can be done that don't really have to do with the actual appointment, right? Mm-hmm. Change what the room looks like and make it more pleasant in here. And then it also, to me, made, again, the conditions where we had this sort of perfect scenario where, well, we do have all we do is behavior management. So is there something that we can do outside of actual appointment that could then generalize? And that's where, not to skip ahead, but where the generalization component kind of became really important, because we knew in our discussions with the director of the dental clinic that we were going to have to do something that wasn't going to necessarily be an overt strategy once the actual appointment was happening.
Oh, that's so fascinating.
When I did clinical work, I had a couple dentists that I had heard did like these types of extra, like outside of hours work, but they were few and far between. And every family wants and needs to know, is there a dentist that can help us or let us come practice, basically. Mm-hmm. It was not all of them that would allow this to happen. And I knew at the time, or I assumed at the time, it probably was they weren't going to be able to bill for this time. And that sort of confirms it for me, Kelly. So these were dentists that had experience working with kids with disabilities and had seen the benefit of having them come in and practice. Because in the end, you want to be able to provide the services that the client needs. And if anyone has been in one of these types of appointments where the child is like clearly upset and frightened, like nothing's really getting accomplished in the way that it needs to. And we all want it to be like a gentle dental approach, right? Where they're not so upset and they've had the practice and have learned some strategies. And we're going to talk obviously in depth about what those are. But there's probably some accommodations that can be made just as far as arrangement of the dental office, like you were saying, Rob, as well as practice that in the end are going to benefit the client if the dentist is sort of forward thinking and able to provide those accommodations and services.
So certainly looking at from the dental standpoint, that article is kind of a nice list It didn't go into a lot of detail. Part of it, like you were saying, Kelly, part of it might be because they know that to go into more detail on something like what are behavior management techniques might be describing treatment that are appropriate, but wouldn't necessarily be able to be implemented unless you were, say, partnered with a school like New England Center for Children or a different school that sort of specialized in behavior management. That might have been it. But the dentist journal, and again, it's not an exhaustive list of what all dentists do. It was just kind of a sample, the top search result, but really focused on using behavior management rather than medication and seeing the benefit there, which I think we would all agree is if you can use behavior management, that is going to be superior to medicating a child or a young adult. They didn't get into too much detail, though. They spoke about use of reinforcement. They talked about exposure. So like show, do, tell, in describing these are the tools I'm going to use, which might work for some folks. I would imagine that if you have someone who is a habitually disruptive behavior to avoid going to the dentist, just telling them about this is the thing that I'm going to stick in your mouth and it's going to make a terrible scraping sound, probably not going to get you where you need to be. They do mention,
well, ideally that would have occurred prior to reaching that point.
You would certainly hope so, yes.
I think it's just respectful to do.
Oh, I'm not saying it's a bad use of time or should not be done, but it didn't go into much more detail than sort of that.
Gotcha.
They talk about relaxation techniques using guided imagery or biofeedback or hypnotherapy. Again, it's kind of a litany of just here are a bunch of things one could do. And I think, from our own experiences, we've seen individuals who have done well with sort of those relaxation techniques, but it's not really for everyone. Like biofeedback, there's some research to support it being useful in certain areas, but it's, again, not universally for everyone, going to show those benefits. Cognitive therapy, again, you have only so many people who are going to benefit from cognitive therapies. And then last resort being either pharmacological management or the use of restraints. They talk about like the papoose board. Kelly, was that something you'd ever seen? I assume it was kind of like it sounds like from movies.
Mm-hmm. Yeah, it's like a stiff board with cloth around it so that your back is on the board and then the cloth is what's actually wrapped around you. And so you're kind of like swaddled, for a lack of a better way to describe it.
Mm-hmm. So there are options, but let's talk about the research into what those options were. And, Kelly, in terms of looking back at, like a history of research, behavior analytic research into assisting individuals with dental visits or dental visit tolerance, it does seem like Allen and Wallace are sort of, they seem to be cited quite frequently. Was that just, I got that from just the sample that we had for the episode, or is that actually the case that they've done?
You're very accurate. Some of the best kind of even bigger picture reviews, I think, have come out from Dr. Allen. He has an extensive amount of research on the topic. He was kind of one of the pioneers in our, flagship journal, the Journal of Applied Behavior Analysis, to really have some of the earlier, contingent reinforcement and then moving into the non-contingent reinforcement, but then expanding with the randomized controlled trials of non-contingent reinforcement. So yes, definitely. And there's a chapter by Allen and Wallace that also really nicely summarizes a lot of the behavior management techniques that are more, behavioral oriented. That's a really, really wonderful sort of succinct review of all the sort of behavioral oriented management strategies in the dental visit.
So it did seem like back in his 2013 article, the avenue of research had to do with looking at non-contingent escape from the dentist. And those had sort of been the articles I think I'd read. Dental visits is one of those topics that will come up sometimes. Someone might ask for resources. I'll go see what's out in the journals right now. And then I don't necessarily think about it very much because it's not typically a topic that I see in my own, kind of professional practice. But I was aware of sort of the idea of, a lot of times it does seem like a lot of the problem behavior is probably functioning to escape going to the dentist or escape the procedures. So some sort of functional communication around escape would be effective. The challenge they seem to have run into in their earlier research was that was now something very challenging for a dentist to engage with. And kind of, Kelly, in talking with you about the idea of the insurance only paying for so much, running like an FCT program sort of in the moment is probably not going to be in the cards for the average dentist. So with their follow-up then, will this work if it's just sort of a fixed time schedule? So like an NCR escape, could we use that? And they set up, I think, just a very simple, randomized control trial in this study, the 2013 study, where they just had your kids who are just getting the standard education. And these are typically developing students. I don't remember them having any giant exclusions other than they had to have passive restraints or sedation, which would probably rule out a lot of students with disabilities, though was not necessarily a component of their participation pool. They had, dental residents serving as the therapists, and they just gave them a timer. They had them show the students in the experimental condition, here's what we're going to do. When this buzzes, you get a break. And they practiced it a few times. And then bam, they went ahead and were told, just do the appointment like you normally would, which meant that the dentist could technically have engaged in restraint or decided they needed to, medicate the child to calm them down. Otherwise, just had a motivator in their pocket that would beep. And when they beep, they'd give the kids a little break from the procedure. They gave them very general guidelines. I was really shocked. I'm very used to like these stringent guidelines of this is how you're going to fade your schedule. And it was sort of like, if you think things are going well, fade it to a different schedule.
Great until you wanted to do procedural integrity.
Yeah, that wasn't quite part of this one. And, they found in terms of the randomized control trial, certainly always interesting to see randomized control trial, because I think I'm so used to looking at our single subject designs where it's like, and everyone looks great, except, maybe one participant doesn't do well, where you have to randomize control where like this kid got the control and they look great. This kid got the experiment and they look bad. There's a different sort of spread of the results. But overall, statistically, they were able to show that the children in the experimental condition where they had the non-contingent escape did, quote unquote, better. They had less disruptive episodes overall. If they did have disruptions, they tended to sort of peter out a little bit. So I think a lot of them, after the first few minutes, once they got through those, they started to actually do better. Whereas the kids in the control tended to do worse as time went on, and they didn't have that contingent escape. Oh, sorry, I meant non-contingent. Okay. It was not, everything's non-contingent here. And in reading that article, you're like, well, you got your randomized control trial. You've got a treatment that dentists seem to like. They really don't have to do very much of anything. It kind of seems like, well, there you go. You got it. That's the treatment. And we never have to talk about this again, right? So in your literature review or in any of your reviews, Kelly, did you have a sense of why this doesn't seem to be the kind of the treatment of note these days? Certainly looking at your article and at the Carter article, that sort of non-contingent escape wasn't really a component. Is there any reason you think that's not happening anymore?
For one, I think, and I'm going to extrapolate from personally the avenue we went down, which in part was that we weren't going to be able to do something like this. In our case, it was explicit in our conversations with the dental director that we were not going to be able to train the dentist to do anything, even though this was modest, and preferred by the dentist. So, pros and cons of that are debatable. But, and then, another thing that we talked about is I think they got up to a few minutes, of the exam and are being able to do a few minutes consecutively. And again, we were trying to shoot for a little bit more than that. And so for us, we wanted to go beyond this. And then concurrently, the Keith Allen has also been a part of more recent reviews that have come out and even painting broader strokes, looking across medical and dental compliance and really looking at, graduated exposure as being one of the more common elements, even though we have some language discussions about, in terms of it being desensitization or that being its own sort of subset or whatever. In that sort of with the considerations in my case that we couldn't, and I wonder to the extent that that's something for a lot of people, unless you have a dedicated dental clinic that you can control the procedures in, and to whatever extent that translates to how billing is run, then this again is possibly giving a strategy that you don't have a lot of control to implement, right? Depending on how much control you have. And so I think, again, extrapolating from why we moved away from that and towards the graduated exposure literature was one, seeing how ubiquitous that was across medical and dental treatments. And again, given the constraints that we had in our particular environment.
That's such a fascinating component that I don't think is captured just due to the nature of kind of the bigger conversation isn't going to be able to get captured in a specific research study. But I think it does kind of continually speak to just how many demands are being placed on any individual caregiver at any one time, because it always surprises me when it seems like, well, this works, we should all do it. And then, well, we're not going to do that because, and then there are usually some sort of reasons, a lot of times financial. which, like you were saying, Kelly, we could debate like, well, I refuse to accept these financial limitations. This is ridiculous. That's not best practice. We could go into that kind of conversation, but that's not going to be helpful because we have nothing to do with insurance reform.
Right. And if you're trying to talk to somebody about how we can make a partnership beneficial, how much are you going to argue with what the limits that they're setting?
I actually did put that in my notes somewhere. Like, why is everyone always complaining about the treatments? If they seem to work, we should do them. And then I complained about my complaint in the note saying like, well, that's a fallacy you're complaining about. So I had my own little argument while I was writing my notes. This was definitely on my mind.
Another thing that as I'm saying it out loud, I might backtrack. So bear with me on my journey. But I think to us too, we were thinking, we were thinking about a population that we knew had this long history of pretty intense, right, reactions to the dentist. And I'm not saying that this necessarily wouldn't be effective in those cases, but we were kind of looking for something that felt, and this is completely just, again, casual and anecdotal, sort of like upping the ante a little bit, and maybe being able to say more so than this kind of a strategy of an abolishing operation, saying a little bit more that we're maybe going to get somewhere with actually addressing phobia, right? Like kind of skirting the boundaries of it. And certainly it's not, the conceptual underpinnings is debatable. And I like that part of it, but moving into the graduated exposure felt like we were acknowledging to some extent also the deep fear and the long history now that these kids had, and sort of felt like we were appropriately going another step.
I think that makes sense, because to do non-contingent escape, you have to have someone who's willing to participate at least at some level, right? So you have to get into the exam to some degree in order to then escape from it. But there's lots and lots of students who aren't there yet and aren't even ready to enter the room or to sit in the chair. So they need even more attention.
Thank you. That's a great way of looking at it too. Yeah, we needed like something immediate, right?
Well, in terms of our dental visit tolerance journey, we've only scratched the surface. But after we come back from a quick break, we're going to talk to Dr. McConnell about her own research and sort of where we are now in the modern lens now in 2020. So we'll be right back with that.
Do you want to be a BCBA?
Sure, we all do.
Now you can come to Regis College in Weston, Mass. to get your graduate degree.
Choose from any one of these courses.
Masters of Science in Applied Behavior Analysis.
Masters of Science in Special Education.
Dual degree in Special Ed and ABA.
Or be eligible for your postmaster's certificate.
You can complete your degree and be ready to sit for the exam in 2 years. And our 2017 grads had a 100% pass rate on the BACB exam.
Come enjoy practicum placement support, ethics mini handbooks, PhD-level professors, small class sizes, and a service trip to Iceland.
If interested, don't delay. Supplies are limited. Learn more at regiscollege.edu.
Again, that's www.regiscollege.edu, regiscollege.edu. One more time, www.regiscollege.edu. See you there!
And we are back talking with Dr. Kelly McConnell about dental visit tolerance. But before we get back to the discussion of her research, I know it's a cliffhanger. It's just going to keep going, folks. I want to make sure that everyone out there knows that ABA Inside Track is ACE approved. By listening to our episodes, you are able to earn 1 learning credit. How exciting! You are going to have to, finish listening to the episode, then go over to our website, abainsidetrack.com/get-CEUs. That's GET-CEUS to enter in 2 secret code words that we've hidden throughout the episode. I'm going to give you the first one right now. It is DARLA, DARLA. Both of these secret code words are courtesy of our special guest, Dr. Kelly McConnell. Darla, you might remember as the little girl with all the headgear from the movie Finding Nemo, the one who kills all the fish, Fun memory of a fun film. Darla. And with that, let's get back to our discussion with Dr. McConnell. And we are back talking with Dr. Kelly McConnell about dental visit tolerance and training and research on the subject. So when we left off, we were sort of talking about where the research had taken us in recent years.
It was a real cliffhanger.
It was real. I know it was a cliffhanger. Will the students get into the dentist's office? Find out. That brings us to your article, Kelly. So in terms of, let's take a quick tangent before I want to just tease it out so the listeners like, no, tell me about the research. I want to tease out sort of the terminology being used because we've sort of mentioned it a little bit. I think, Dinah, you mentioned a little at the top of the episode. I think a lot of folks, when they're talking about this sort of dental visit and, getting individuals who, have a dental phobia or just are avoidant of the dentist, getting them to the dentist, we talk a lot about it using a term like desensitization to the dentist. So certainly the Carter article talks about dental desensitization. It's in the title. But in your article, it's not mentioned, and you mostly refer to sort of a similar process as graduated exposure. So let's take a minute and talk about why you would not use the term desensitization. Are there reasons for one versus the other? If not, what other terms should we be using and why?
Sure. Again, this is kind of going on a little like conceptual journey, which I find fun. You can redirect me at any point if it didn't even start or stops being fun for anybody else. Again, I've mentioned a couple times another more recent sort of review that was published in a book by Allen and Kupczyk in, I think, 2016. It's referenced in my article that really nicely, I think, sort of laid out, for me, it was really helpful to hear them talk about some of these minced terminologies. And I think, there's a couple of things. Like you said, the term desensitization is definitely used almost like Xerox, kind of generalized to some extent. And where we want to be careful is where you don't then explain exactly what you did and didn't do, right? So I don't know how important it is to never use that term as long as you then technologically explain what was included so that somebody else could go behind you and, replicate and even before that, know what you actually did and what you didn't do, because the term desensitization has a long history that usually includes, some sort of breaking down of the procedure into more tolerable sort of units. That's the graduated, and then, exposing it in a graduated nature. And then desensitization usually also has some sort of relaxation component where there's some sort of response that is theoretically incompatible with being afraid and all the respondent nature that happens with being afraid. So if you are relaxed, you cannot also be tensing your muscles, right? And so historically, the term desensitization tends to imply that something like that was done. Now, fast forward several years and the term is being used more generally. And so again, I think the most important part in terms of just terminology is that if you are going to use desensitization, that you then explain exactly what you did and didn't include. And then, what several reviews note is, and I definitely can echo this in my own searches, is that many times the terms are graduated exposure and desensitization are used sort of like interchangeably. And then you kind of have to look carefully to see if it really was as simple as, taking the whole demand and breaking it down and exposing the patient in more incremental, theoretically more palatable components versus, did you do some sort of relaxation procedure, which is more outside of our comfort zone than graduated exposure. We do have some, foyers into that in our field, but certainly personally, I felt much more comfortable with understanding what was involved in graduated exposure and more comfortable in terms of execution.
So to some extent, it isn't just, both terms mean the same thing. You are often talking about different procedures in terms of the components that you would expect or not expect to be included in whichever term you use. Yeah,
I think if you're being really sound in your verbiage, again, I don't think that's always the case. And so then it becomes really imperative that the authors of the research explained what was and wasn't included, which the Carter article very nicely laid out exactly what they considered to be included in their desensitization package, for example.
I think that distinction is really helpful.
Mm-hmm.
Thank you for that. I've also heard individuals from the autistic community speak on the term desensitization and say that their response to something as overstimulating as a dental visit just is never going to truly be quote unquote desensitized. I don't know if I said that right.
Just desensitized.
Okay, I added too many in there. Desensitized. And so they may sort of get better at the process, but it's still going to be a grin and bear it situation. And they're still going to be experiencing everything at this sort of really high rate of input of all of these various stimuli. So I guess, we don't necessarily know what our clients are experiencing in the context of the dental visit. And maybe if we just call it teaching tolerance of the visit, then we don't have to get into the nitty gritty of what that experience is truly like, as we may not know.
Mm-hmm. Yeah, no, I like that. Certainly any kind of perspective like that where we can be more sensitive, why wouldn't we anyway? So there's another vote then to be careful with our words, right?
Yeah.
But not desensitive. We want to be sensitive.
Good work.
That's all I bring to the conversation. It's quite sad.
Solid work.
So let's get into your article and your research. So graduated exposure, you sort of explained before the break kind of why that seemed to be the more preferred, maybe preferred is not the right term, but sort of the lines of research that certainly folks like Alan and Kupsik had been going down, your research, the Carter research. So could you just kind of briefly describe what typically goes into the graduated exposure procedure, specifically in referring to our dental visit tolerance?
Both in dental and medical, the idea is that you are, again, taking the end goal of usually a full routine of some kind, breaking it down into steps, also something that we're very used to doing in a teaching format, right? And then exposing or sort of having the individual go through, and some are more active and some are more passive, like you might just need to tolerate having the mirror in your mouth versus actively walking into the room, but sort of incrementally having them engage in that response or exposed to that response, and then not adding on additional steps or components until you have some indication that they are doing well with it. So, usually there's a behavioral criteria. You could add some, affect kind of additional parameters onto it, although that can be tricky. But, some indication that they are ready to have a little bit more. And again, the other nice thing that does is it kind of takes the, something that's common in a more traditional desensitization treatment is making a hierarchy of less feared to more feared stimuli. And that can be done, even in our populations that we work with. But this is kind of almost like you can kind of do that from the outset and then do some sort of baseline or test to see, at what point in the routine does it seem like, for a lot of kids, for some kids, they maybe will walk into the room and are like, this is fine. But as soon as you tell me to sit in that chair, it's like game over. Now I know what you're doing. I don't want to do this anymore. Others, the stimulus control might be so strong that even just the sight of the room is, as Diana said earlier, you're already gonna have noncompliance. But theoretically, so in that case, you would know, during your baseline or whatever your initial assessment, that it's as early as walking into the room that we're gonna have problems. So no way am I coming at him with a mirror or a scaler, if we can't even walk into the room. So we're starting at like square one, right? So it gives you some of that information about where to start and then an incremental way to sort of increase.
So that's sort of been a component in other research, like we mentioned you mentioned citing Alan and Kupsik's 2016 chapter. Certainly, we've talked a little bit about the Carter study with graduated exposure. But in terms of looking at the research, one of the things you found, and I guess the reason it's sort of prominently displayed in the title of your article is none of these other studies that you looked at had ever done an FA and actually looked at the function of the disruption during a dental visit.
Yeah, and so that's funny because this was quite a decision point for us. And this actually became more of an important decision point for us when we decided to use extinction, when we knew that was going to be a potential backup if graduated exposure alone didn't work, because if you're going to talk about something that carries the weight of extinction, whether it should or not in all conditions is debatable, but if you're going to suggest that that's the natural outcome if graduated exposure doesn't work, then we better make sure that we have matched, our function appropriately. Not to say that it doesn't have utility outside of that, just to ensure that problem behavior in a dental context is escape maintained, although most people, would agree that that's one of those cases where you can be probably pretty confident. But again, for us, it really, once we decided that we were going to add an escape component, an escape extinction component, and looking at the sort of like not how that had been done in some studies, but not all, escape extinction that is. And in some cases, you're like, I think that's what they're saying they did because they just didn't go away, but I can't really tell if that's what they did. But in very few cases, any was it, demonstrated. And so then you're in that kind of circular position of not even being able to really call it extinction if you're not sure. And so we, that's really the piece that made us want to include the functional analysis piece. Plus, it was kind of an interesting application of the functional analysis, methodology, and a way to sort of also demonstrate that you can be sort of like compliant with normal demands and still find the dentist to be particularly scary. Because otherwise, if it's all demands, then you probably have another course of treatment that's needed, right? Some general compliance training that needs to happen first, but to demonstrate sort of definitively that it's these demands in particular that are horrific, if you will, then it made us even more confident in sort of what we were suggesting as a progression.
So the inclusion of sort of the, you have your control, you have your demand condition, and then your dental demand condition.
Yeah.
Sort of the new arm of the FA.
Yeah.
But that was in there from the beginning in terms of just, how are we going to do an FA? What conditions will we include? There was always going to be that demand versus dental demand that you always wanted to have that distinction, or did that come later?
My lovely advisor, Dr. Sassy, who is raised academically in the functional analysis sort of arena at the University of Florida, it was fun to kind of bounce these ideas off of her. And I actually really liked her. This was actually a lot of her contribution in suggesting having that typical demand versus a dental demand, again, so that we could say, we're not going to just address this with any old treatment that's specific to tolerating any demands. This needs to be a specific dental, appropriate treatment that we're going down, therefore informing the graduated exposure in some part too. Yeah.
Mm-hmm. So there wouldn't have been much article if, surprisingly, there had been no dental, there had been no escape.
Turn of events. Yeah.
What a twist. Oh my God. They all love the dentist now.
And I'm out of a research topic now.
So you got the results you expected. Well, I guess maybe you might not have been able to know for sure until you did the FA that it wasn't so much the demands, it was the demand of dental procedures. That was where the escape came into play. So you had a pretty good sense at that point what treatment would most likely look like. You wanted to use graduated exposure, but you understood based on the function of the behavior that there was going to be a chance, much less than zero chance, that escape extinction might need to be a component of the final treatment.
Right. Yeah. And so then you get into this, the processes that theoretically are at play in graduated exposure is respondent extinction. Again, some of the research leading me down this path was saying, then you can really complement the respondent extinction with dealing with the operant behavior. And there's considerations like positive reinforcement and consider escape extinction, but here's some concerns. And so then we were kind of at a crossroads there with, we're going to give graduated exposure a chance, because another thing that we haven't really talked about yet is that even when people are sort of more technological about what is included and not, graduated exposure is most often done in a like kitchen sink kind of like, let's just give all of our efforts here, which makes sense to some extent, these treatment packages, but it's like a catch-22, right? So we're going to like throw a bunch of things at this, and clinically maybe that makes sense because we need to get this taken care of, but then you're in the position of clinically not knowing what worked and what didn't, and then it's still having some resource intensity, which was always a concern of mine. So we really wanted to start with graduated exposure at its core and see what that alone did, because that was also relatively absent from the literature. So what do we do? What do we see? Do we see that, theoretically that respondent extinction is enough or is effective? But what are we going to do about problem behavior that we know has had a long history? How are we going to deal with the operant hand of it, right? And kind of going down this avenue of how we wanted to address it. And the reason also that extinction kind of came to mind is not only because of who we knew we were dealing with in terms of likely participants and that long history, but also that really like easy, at least for me, analogy to demand fading, which we know is an effective, strategy for escape, maintain, problem behavior. But the literature is pretty clear that escape extinction is a facilitative component with demand fading. Mm-hmm. So we kind of were going down this road of knowing we were going to try graduate exposure by itself, but that we wanted a backup, right? What were we going to do next? And we also were confident that we could do a pretty non-invasive escape extinction procedure in that we weren't going to force anything. We weren't going to be at all dangerous. We were going to just kind of be like nagging. And that's kind of what we called it. Like, I'm not going away. I'm still here. And at this point, if you just do this one little thing, you can be done, right? And so, when we talked ourselves through it, it wasn't, we knew we had to look for certain things that might happen and, bursting and some other, things that might occur, but we're like, maybe not. And then we'd be able to show, again, some of that analogy to what the research suggests about using extinction with demand fading.
Mm-hmm. So in practice, you had your dental, it was a dental simulation room. This was at Franciscan's, or this was?
This was at NEC because Franciscan was like, no, you cannot come here outside of clinical time. Please don't show up after hours or in between hours. You can't come at any time that is not a scheduled session with your students. So yes, it was a room at NEC.
Pretty much you got to get it right before you get to go to the real dentist.
Yeah. Well, they were going to continue to go on their normal schedule, right?
Sure.
Yeah. But yes, here's our practice area where we are devoted to behavior management. We have 1 million people that can come help us should we need it, right? I mean, like, really, that's kind of ideal in some ways. And then, of course, for stimulus control and trying to really stack the deck in our favor in terms of generalization.
Sure. So in terms of your overall starting procedure, you were starting with the graduated exposure. If the students completed that initial step, which I think step 1 was just get into the dentist's office or enter the room, right? Really easy. Should be a slam dunk, right?
Oh, yeah. Come on. But for some it wasn't.
That's true.
Yeah.
And if they did, they'd get praise. If they engaged in disruptive behavior, aggressive, any sort of aggressive behavior, they had a 30-second, you sort of wait 30 seconds? Should have given them 30 seconds?
Yeah, I kind of just like turned away and acted like I wasn't going to do anything. Like, okay, all right, whatever.
Right, and then, like you said, you wouldn't necessarily nag them. You would just present the same step again, at least during those initial graduated exposure component, right?
So during graduated exposure, we presented a certain amount of steps, and that was it, so that we could kind of control for not going too far. So it was, I'm presenting 5 steps. I'm going to, every time they engage in problem behavior, I'll turn away. But that means if I presented step 4 of the exam and you engaged in problem behavior, when I turn back around, I'm presenting step 4 again, but then we're stopping because that's 5 total demands is kind of how we conceptualize it. Because again, you're going to see compliance if they're ready to move on to a more advanced step in the exam. So that was for the just graduated exposure.
If they completed, they reached the target, like, hey, surprise, they got through those first like 5 steps or whatnot. They had a certain amount of time. And after that, they would go to read in the waiting area. Which nobody read, let me tell you that much. There was no reading going on. They were basically like, thank God you're just not in my face anymore. It was basically, we had highlights like you see at every dentist, which I think are so charming, highlights, magazines. And it was basically like, okay, you're done, but you have to kind of sit here. And we were trying to control for sessions that were going to go longer versus something that, if it's only step 1 where you have to walk into the room, that's theoretically going to take, seconds. And so then they could and it was obvious that the session, that the dental routine was done and that they're just sitting there, and then they could choose from, as Jackie said, a junky like sticker or sticky thing or something, out of a bin when they were ready to go back at the end of that time, because that's what you get at a lot of actual dentists.
Kelly, this is my favorite part, I think, of all of your study. And when I was attempting to do some dental work during COVID, which was so silly, but we started
on yourself, Jackie? That's not safe.
We had a study that we were going to do, some research that we were going to do, but we started it pre-COVID, and then we were ready to go during COVID, so it got rejected by the IRB. They're like, it's a really good study, but COVID. And I'm like, I know. But this was like my favorite. And we put this in the study. Kelly was on my students' committees because I think this part's awesome, right? Like, just get up, right? I love that. They can just get up and like not be there. I just think that is.
Which is kind of like, you might as well just, just do it. And it's going to be, well, certainly once we add extinction, like just do this and you're done.
I love that piece. And I think, we should really highlight that piece is that you weren't forcing anyone to be in that chair.
No.
Right?
Yeah, definitely not during graduate exposure. I was like, okay.
Right. You can get up, get out of there. Like you can walk around, but you can't leave.
Right. It would be more efficient at this point to just do it.
And Kelly, that seems like the big difference between some of the other research, or specifically the Carter research, where there was that, differential reinforcement. There were like, edibles being provided. I think they provided candy for completing certain steps. In this case, it was, you can't leave. At some point, you get to be done. Let's give it a try. If you don't, okay, well, we'll wait, we'll look away and then try again, which I think there's a level of, respect for the individuals you're working with, some bravery on your part in terms of we're going to go for it. Let's just see what happens. Because, if you just describe this to me of like, well, it's adolescents, with autism, they have a, long history of not, really enjoying going to the dentist. And you describe this treatment to me, I'd be like, that sounds like it's not going to work, but whatever you want to try, it's your research.
No, and we're like, but let's, the idea is that if exposure alone, right, is enough. And I have in the back of my mind how I'm, a creep about the dentist now. And so there's this part of me that's like, there's something about repeated exposure, perhaps. But, that's what we wanted to find out. Like, is me telling you to walk in the room enough times, enough that we're going to see some obvious change, right?
Mm-hmm. And in terms of those next steps, you had your criteria to sort of add steps to the, graduated exposure procedure, but you also had your criteria for when the escape extinction was going to have to be implemented as a likely component. And overall, it did seem like the results were pretty variable across your participants in terms of some students making it, decently far just with the graduated exposure alone, and others not getting that far and having the escape extinction a little bit earlier.
Yeah, you could tell. And again, we introduced probes at a later time. That was kind of something that we figured out along the road after, David, who had a lot of sessions, for example. So the clinic, not the dental clinic probes, but just, treatment probes. And so one of the things that it started to be obvious is that there seemed to be, there seemed to be trigger points too with in the graduated exposure of like, I'm okay with this. Nope, we're not going any further. And it was usually around like getting in the chair. It was usually around, something like that. And so, Rob, did you say that there was a difference in how far people got before meeting extinction?
I want to say Wes, I think he made it to pretty far, like step 12 or something before escape extinction was added.
Billy, he went longer. Yeah, and it was like hanging out, and then he was just like, then there was this nice little like decline. Things got worse. Yeah. It was funny. Yeah, we're like, how far are we going to get with this? He's going to be our outlier, and then it deteriorated. He had enough finally.
Yeah. And it was a pretty thorough. I mean, I know it was like sort of the mock fluoride and some of the mock scaling, but it was a pretty, reading the description, it sounded like, yep, that's what I do when I go to the dentist. So it was very much what you would expect to see in a full dental appointment, at least for basic care.
Yeah, for a basic, like what they call prophylactic or preventative care. And that's even like a point that I like to talk about, because when we were talking to the dental clinic director, Wendy Cheney, one of the authors, she was like, I just want them to do a basic exam too. Like, we're not even, and that's why we stuck with that. We're not even like worried right now about x-rays or anything more invasive. Like, we're struggling. And that's anecdotally what I had seen for years and years of attending these appointments is like, we're not even getting a thorough cleaning, which is absolutely like, you can go a while without x-rays. Theoretically, you can't keep going on and on and on without having a decent cleaning, without having just the compounding, health effects of that. So,
and dental health is so important.
It's so important.
Right? Oh, thanks, teacher. I mean, it's so important.
It seriously is. Like, it's not just limited to your mouth. Your dental health and your gum health affects your entire body.
Yes. I need these pearly whites. They're the money makers. You're gonna flash those, and
That's
everyone's like, "Oh,
It's everywhere.
That's a
No,
big
but
smile.
it's like serious. It's tied into your heart health. And your
No, it is.
overall.
My dentist, an interesting aside quickly is when I was at the dentist the other day, he said that, things had closed down for COVID. And then when they came back, tons of people are having so many problems they didn't have because everybody's grinding and like stressed out. And that's like wearing down their teeth. And so like people are having problems that they haven't had for years. So like, yeah, it's all related and take care of your teeth.
It sounds like big dentistry has gotten to both of you. And
Big dentistry. Yeah, definitely. It was important that while we were sticking to like a basic exam, that we were kind of as like good about it and setting ourselves up again for generalization as much as possible. Like, let's make this at least not like, this can't just look like you're brushing your teeth with your teacher, which you do all the time in the residence anyway. Like, this needs to look different, right?
Yeah. So eventually everyone did need to have escape extinction added to the procedure. And I certainly always love it when we have an author on the show, like hearing a little bit more about escape extinction, though you did describe pretty well in the article sort of what it looked like, because I think we've all had different experiences when we've used extinction as part of a procedure. We've seen a lot of that kind of reactivity. We've seen, huge bursts of behavior. You paint quite the picture in terms of, I think it was David who started hiding under the chair, when escape extinction occurred. There was Billy who just kind of was like going everywhere. Like he was just, I'm not having any of this dental appointment. But would you kind of mind describing sort of what the escape extinction looked like? You mentioned nagging kind of earlier.
Not a technical term. Yeah, we basically were like, I'm just not going away. So it needs to look different than, in the previous condition when I would obviously withdraw, my tools and give you some space. And so I was basically just kind of like not doing that. And I would stay there depending on the step, right? Because there's some that you could kind of like, like gently be next to the person and maybe guide them like sitting in the chair versus where I had a dental tool. I did not force anything in their mouth. I just like stayed there. So almost, I don't have intimate knowledge of a lot of the food studies, but some other people I've worked with have talked about it being akin to like non-removal of the spoon during feeding treatment, where you're just like there. And so there was no, it wasn't physical hardly at all, unless it was a physical step like walking in the room. But even that was like gentle kind of guidance. I was just there so that it was obvious that I wasn't going away. And that's what I still wanted them to do. And, like if it made sense to repeat a verbal prompt of the step every once in a while, so that again, it just needed to look different than when I obviously gave them space and gave them a break.
No one's getting chased down with the scaler or with the fluoride polisher or anything.
Honestly, the most physical aspect was when I also had to get on the floor to follow David under the chair. That was like, and I was the most sweaty person in the room by a long shot. He was like just loving it and thought it was actually hilarious that he could fit himself under the chair. And so I just got like down on the floor with him like this. I'm still making you do this even if you're under the chair, right? And so that was really, and I can say personally, I think with, Billy was like our definitely like a more intimidating fella, taller than me, bigger than me, and kind of like knew how to use his weight, in a very effective way, which is why in part we were where we were with him. And so I will say, he's the one that his behavior looked sort of the most like a burst, like an actual burst, right, when we did extinction. And I will say, maybe like in one session, I was like, ooh, if he wanted to, I'm really close to him, so he could definitely engage in some pretty severe aggression to me. And I think he maybe pushed me out of the way. And that was the other nice thing is we made sure that sort of like, active resistance was included, so that all you had to do was like resist me. And I was, and that was, I think that response took shape early on in the graduated exposure phase. So he didn't up the ante very much, even under extinction. So our experience was really, really very okay. It never felt like, like we were chasing anybody down. It never felt unsafe on either end. And that was really, really important to us. And so it was, we were really comfortable saying that it was very non-invasive.
Definitely the way you describe it sounds very different than I think I would sort of just what would pop into my head in terms of if you said I would use escape extinction, I would usually assume something that's much more, hands-on, like you're really getting, into a student's space. And I think it sounds like nagging is very much, while not a technical term.
Right.
Colloquial
it totally
descriptor.
It totally fits. Yeah, no, it's exactly what we were doing. We were basically annoying. It worked. So yay.
In terms of the final results, I mean, within the clinical setting, the students all were able to complete the steps. Then with the generalization probe, so going to the dentist, and that was always going to be a generalization probe, right? Because you pretty much had to just, we're going to the dentist today and it's going to be what it's going to be. You're not going to be able to follow the procedure, right?
Yeah, it had to fall when it fell on their cycle. Like we couldn't do anything extraordinary with that. So it was like, here we go, wherever we are, wherever they've gotten in treatment, here we are and here we go.
Overall, I mean, it seemed, I think, one of the participants did better, but not quite as well as he'd done in the clinic. But I think 3 of them were almost either 80% or above in terms of the completion of the routine.
We were really, really happy with this. And, this is it's the least rigorous part of the study, but the one that like speaks to me the most and makes me like the happiest and the proudest of this research, honestly, because that's what we knew we needed. And I would have been even modest changes in a positive direction, lowering restraint, which happened, that was pretty big, and getting through a little bit more. We knew with the group of students that we selected that what we were kind of in for. Wes, for example, didn't have an initial appointment because he was precluded from going to this clinic because of how bad he was.
Wow.
Wow.
Yeah. And so that's why he doesn't have an initial probe on there. So just to get him in the door, and like that's the stuff that like it literally almost like makes me choke up thinking about some of these kids where they started and what we were able to do in the clinic, even though again on paper it's not quite as, it doesn't translate as strongly as the clinic data. It was like, I remember calling Jess on my way home from one of them and being like, oh my God, you cannot believe how he did so good. Like, I can't believe it. And so this is like very important to me.
That's so excellent. It must be, such a great feeling to sort of have put all this time in and to be able to then just, you see that product, you see this successful appointment, or even if it was not fully successful, just significantly more successful than previous
incrementally. Right. Yeah. We got somewhere.
So again, it did seem while graduated exposure was able to be pretty effective for some of the early stages for all the participants, the escape extinction did seem to be a required component in terms of completing the entirety of the dental exam. You had some sort of, kind of thoughts in the discussion section as to what processes might have been in play, why you saw the results you had. Do you mind kind of sharing those?
I think generally this echoed very nicely, it echoed even further the demand fading literature again that suggests that extinction is a facilitative component. I think this also nicely echoed what some of the reviews were saying and why really graduated exposure tends to be used in a package is because on one hand, with the graduate exposure, you're tackling hopefully, theoretically the respondent, can attack with respondent extinction, and then in many cases enhance it with how you're going to deal with problem behavior in session. And so I think, it really nicely echoed that. One of the other recommendations was in the literature is to use reinforcement of compliance as your operant strategy. We actually clinically extended the research a little bit with a couple of students who, for various reasons, their folks didn't want them enrolled in something where extinction was going to be the likely outcome. So we actually started on a more intensive differential reinforcement kind of schedule, but it was more clinically minded, so it didn't make it to this output. So I think, even since I've written this, but we say it in the discussion is that, obviously what we don't know is how effective differential reinforcement would have been. There's some concerns about contraindication if it's edibles, which is like, of course, what everybody, on my team, or, with
the gummiest taffy,
oh my God,
right in the middle
which is like every dentist's like worst nightmare. Or in the clinical extension that you don't see in here, we were like taking iPads out of kids' hands between steps, which was also like, this also just doesn't feel kind of like what I want to be doing, So I think that there's obviously a lot of research suggesting how effective, obviously, adding, strong differential reinforcement as a component also to graduate exposure and how successful that can be. And it's almost hard. It's hard for us to swallow not having done that first, and having that to say, because it's hard to say like, why didn't you try differential reinforcement first? But we had kind of a strong avenue, and hopefully that my explanation kind of how we arrived at what we did want to do was helpful. And then I think, again, what we can kind of take away from this is that in these cases, it might have been that we were dealing with particularly long histories, right, of negative reinforcement, which probably kind of just added to this general experience. And so for this set of students who we knew we were picking kind of like, they were referred to us because this was a problem, I'm not surprised that we needed to address the operant side of it, and that whatever was accomplished in graduated exposure, maybe if we had gone down that road longer, who knows, but it was certainly more efficient at some point to add the extinction.
And certainly looking at the, like the Carter et al. Study being kind of an example of what you're speaking about in terms of here's how differential reinforcement can be used. And they were able to fade, the use of their, whatever the gummy food, or I don't remember. I think it was sweets. They mentioned it was sweets in that article.
It's gummies. It's always gummies.
Oh, no.
No, I'm just kidding. I don't know, but it's always gummies.
The odds are, the odds are not going to be in your favor. It's going to be something that your dentist is not
happening.
And it's hard to do like a direct comparison in terms of time, but it did seem that at least for one of their participants, it did take quite a long time to sort of move through the steps of the procedure. Again, some of that might be because they were using, a changing criterion design, which inherently you have to take a little bit longer to make sure you're, having good experimental control. Then your participants, who some of them took about as long, but many of them took shorter time of the escape extinction. And, could time be a factor? I mean, I think when we're talking about students who haven't been to the dentist for some, number of years or months, potentially it could be.
This is a lifelong skill.
Yeah, exactly.
As well. So if it takes time, that's okay.
You're okay to have the time because you're going to go back to the dentist every 6 months or possibly more frequently.
Towards that end, maintenance is like my next, the idea of ending here was like kind of hard. It was almost like you got to step away. So we train the teams, and we're like, please keep doing that. And I think the teams, to the extent humanly possible, were like, we got to keep this up. But, we didn't follow up with that because another student out of Just Sassy's lab did some research with, to some extent, looking at time in between, sessions and stuff like that, which is kind of more on the top end, more so than the maintenance end. But I think that's another avenue to think about too.
Well, Kelly, it's such a great discussion of sort of the process of your research, as well as the results and the clinical take homes. So this seems like a good time to move into the last section of our show, which is the dissemination station.
We're here.
Oh, I'm so excited.
It's a great vacation destination. This dissemination
we only see
station.
the station, though. We don't even know what's in the surrounding area.
There's just research lying around.
Research.
Ooh.
The ground just littered with research possibilities.
I feel like we should have some sort of guests, maybe inside track, get to go visit the rest of Dissemination Town.
Oh, God.
There's water slides and buffets. Well, as far as the eye can see.
Are there
everywhere.
toothbrushes and floss that I can take with me?
Everything is fluoridated in Dissemination.
Sign me up.
So this topic is a little tricky in that not every professional who's listening is like, man, I just need to figure out what to do to help with dental care for my students. But for most individuals, if you are working with families or you're working in a school setting or wherever you're working, eventually the question will come up. Because like we talked about, the dentist is going to keep coming up of how do we get my child, my young adult to the dentist? So in terms of kind of, principles, procedures that you think are important for listeners to be thinking about when it comes to dental visit tolerance, what are kind of the big sort of take home points that you really gleaned from your own work and your own research?
Hopefully this doesn't contradict anything I have already said, but I do think that there is something about, like if we could kind of like capture that idea of inoculating against problem behavior and a poor experience early on to the extent humanly possible. So certainly if you are in a position where you do control the contingencies around being able to be in a space for more time, if you're a parent and you can do anything that is giving them extra experience with what it's going to be like, especially if you suspect any kind of dental fear early on, the same with medical procedures, I would think, capitalizing on what we can control and knowing that to some extent exposure is something, right? There is something about exposure, whether it's going to get you all the way or not, there is something valuable there. And I can imagine if you can control exposure at all, you can also probably control, maybe to some extent you can control what happens in response to problem behavior, even if it's in a more limited context. So I think, somehow trying to prevent these long histories of, successfully avoiding the appointments and these long histories of making it such an aversive, thing, anything that we can do towards that end. And then at the very, very least, making sure that oral health, that poor oral health isn't going to make anything worse. Like, then if you get in a history of having, anything that makes routine dental work even more painful, then you're probably not going to be doing yourselves any favors. So thinking again, really, really broadly, I think any kind of exposure, you might as well try, right? And see if there's any value to that. And then any amount of, and like Diana said, if you happen to know of any opportunities to practice in extra settings that aren't the normal where they brush their teeth with people that they know, any kind of thing that can kind of make it an event, right? And get that early exposure, then I think that is, try to capitalize on that early on so that you're not in a position where it's years and years and years of this kind of like snowball effect.
I think to build on that, any additional types of accommodations that we can make initially when clients or students are first visiting the dentist. So would bringing a favorite, stuffed animal or, preferred item with them help? Would wearing noise canceling headphones help?
Definitely.
Would being able to ask that a certain favorite video is played? A lot of times they'll have like the screens up on the top of on the ceiling. Would that help? Could we practice visiting in just short increments? Are there, preemptive videos that we could show or stories that we could review to help make this visit more predictable for the child, to help them sort of understand what's going to happen in this really unknown and scary setting? Any of those components. And I don't know if there's a lot of literature on that or not, but it makes sense that those would be helpful strategies to include.
Like you said, I think almost regardless, the literature is really mixed on a lot of those. But again, I think in those cases, we're often looking at kids now that have a long history in some cases, right? That's who the studies are being done on. So if we're talking before that, preventatively, why not try some of those things that are lower effort and are sort of like respectful, kind of, humanistic anyway. So why not try, even if the literature is mixed? Because again, in those cases, I think we're talking about it maybe being a little bit too late for that kind of more, softer antecedent kind of manipulations.
Well, Kelly, thank you so very much for bringing this research out for individuals. Thank you so much for coming on the show tonight. It was a real pleasure getting to talk with you. I think it certainly went well beyond just sort of what goes into the research paper, and a lot into what goes into the development of research, what goes into the thought process behind why we do the research we do, which I think is so exciting for a lot of listeners who might not have had the opportunity to engage in structured research like this before. So we just want to say, really thank you so very much for that.
Yeah, my pleasure. It was very fun, really fun.
Oh, good.
I better put out some more research so I can do it again, huh?
Kelly, get on that. Get on it, Kelly.
Just for this, just so I can have this conversation with you guys.
If individuals are, facing challenges with working with clients who are struggling with visiting the dentist and they want to reach out to you, is there a way that they could do that?
Sure. Yeah. My email is probably best, which is kmcconnell@necc.org, which it's also probably somewhere on this paper, right? Isn't that a thing?
Yep, it is on the bottom.
It is.
There. So that might be easier than me spelling how many doubles I have. So certainly the email in this research paper, which is, as Rob said, hot off the press right now. But yeah, please reach out. I love to talk, obviously. And if you want to tell me your personal stories about the dentist, I also like that, obviously. So please, I'll talk to anybody about dental anything.
It would be hilarious, Kelly, if you're like, yeah, here's my address. Stop on by at any time.
Yeah. Like, no.
Only with your dental questions. Only with that, though.
Yeah. I'll put some boundary conditions on. Yes. Yeah. Well, thank you, guys. This was fun.
Big thanks once again to Dr. Kelly McConnell for being on the show and talking all about her research related to dental visit tolerance. It was a real pleasure to have her on. Sometimes these things happen. Sometimes we're able to get guests way in advance. Sometimes we just have scheduling snafus that keep guests from coming on. This was one of those rare times where we had a scheduling snafu that actually allowed Dr. McConnell to jump onto the show. And we are so happy that she was able to. It was just such an exciting conversation about a really important topic for so many individuals. Before we wrap up the show, I want to make sure to give everyone out there their second secret code word. It is prophylactic. Again, courtesy of Dr. McConnell, prophylactic. I'm going to spell that for you because that was one I was not sure how to spell without looking it up. Prophylacitic. And again, that refers to something in medicine usually that is preventative. I'm sure some of you are thinking of a different way we use that term.
Get your mind out of the gutter.
But we're talking about preventative procedures when we talk about prophylactic. And with that, I guess that brings us to the end of another episode of ABA Inside Track. We want to say again, one more big thanks to Dr. Kelly McConnell. Huge thanks also to all of you out there listening to the show. We want to say thank you. There are a lot of ways that you can let us know how we're doing with the show. First of all, you could maybe subscribe to us on Apple Podcasts or Spotify, Stitcher, wherever you want to get your podcast. And then after that, you can leave us any feedback you would like, whether that's a review on any of those sites or by reaching out to us through social media. We're on Facebook, Twitter, Pinterest, Instagram as ABA Inside Track. You can certainly find these episodes online on our YouTube page as ABA Inside Track, where we have the subtitling feature enabled. You can go to the website as abainsidetrack.com to leave comments, also to find links to all of the articles discussed tonight. Of course, we also have a new endeavor, our Patreon page. Patreon subscribers can get access to additional book club podcasts for additional CEs, as well as bi-monthly social meetups and much, much more. All of that is on patreon.com/ABA Inside Track. And of course, if all of those fail, you can always send us a good old-fashioned email at abainsidetrack@gmail.com. Before we finally wrap up, I want to say big thanks to the folks who help us make this podcast, certainly Jackie and Diana, my fabulous co-hosts. Also, Dr. Jim Carr for his recording of our intro and outro music, Kyle Sturry for his interstitial music, Dan Thabit of the Podcast Doctors for his editing work, and Hollis Irvin from the Sycamore Workshop for his visual designs. We'll be back next week with another fun-filled, full-length episode. But until then, keep responding. Bye!
Bye!